interview. This is a webinar on Massachusetts Medicare for All ballot question that's going to be in 20 districts across the state. You can go to masscare.org to determine the exact nature of where the 20 districts are across the state. We are coordinating Speaker Mariano's district and doing door-to-door advocacy on this issue for him. And we also have a wonderful speaker coming up. We do have the brochure that is available here. I'm showing it to you on screen. Hang on. So the brochure will show it to you afterwards on the screen because we've got the screen share for Alan Meyers' presentation up now. But this is a vote yes on question 5, Medicare for All. And we thank Medicare, MassCare, and we thank Mass Peace Action, Healthcare Not Warfare committees for putting this together. Dr. Alan Meyers is a leader, national expert on single-payer healthcare, and he's been a wonderfully strong advocate for healthcare reform and public health leadership over many, many years. So we are thrilled to have him here, and we thank him. He can go ahead and start your presentation, Dr. Meyers.
Well, thank you, Bonnie. I'm sorry that I might have cut you off there.
No, that's fine.
Start sharing the screen early.
No, it's fine. Yeah.
So let's start with an anecdote.
This is the most important stuff.
Here's a story. Was reported early in the pandemic. A 17-year-old young man in LA County, sick with COVID, presents to an urgent care center, an urgent care clinic, but he's turned away because he doesn't have health insurance. He's told to go to the nearest public hospital. En route to that hospital, he dies. Now, of course, we have no way of knowing if his life could have been saved had he been seen at that urgent care clinic, but I would just offer this as emblematic of the situation we find ourselves in with our currently dysfunctional healthcare system when we were clobbered by this COVID pandemic. Here's a paper from this past June from the Proceedings of the National Academy of Sciences. These authors estimate that thus far, this is through June, 338,000 COVID deaths are attributable to incomplete insurance coverage in the US. And the excessive costs of those illnesses is over $100 billion. So it's no surprise that when you look at years of life lost, of loss of life expectancy in the 37 countries in the middle to upper income range, we are the worst. We are doing worse than everybody except Russia. Now, if you're fortunate enough, let's say, to have health insurance, if it's employer-based private health insurance, but you're unfortunate enough to get admitted to the hospital with COVID, the average cost you're going to spend out of pocket is almost $1,500. That's on average. That's in addition to your insurance. You're going to pay that out of pocket. That's what the national data show. But it might be much higher. Here's a case that was reported in the New York Times of a man who gets sick, he spends multiple months in the hospital, sick with COVID. He's insured, but the insurance company that he's insured under rejects almost 100 bills, leaving his family with a medical debt of about $400,000. So we're going to come back to this, the inadequacy of employer-based private health insurance. That's one of the themes for tonight. But it hasn't stopped, all of this has not stopped the profit taking by the largest health insurers in the United States. 5 of America's largest health insurers reported more than $11 billion in profits just in the second quarter of August 2021. They're doing just fine. In part, that's due to the fact that healthcare utilization for everything other than COVID has fallen during the pandemic. So that brings us to what we might consider the US healthcare paradox, that amongst all wealthy nations, we in the United States have the highest costs, the highest rate of uninsured and underinsured people, and the poorest performance. Let's unpack each one of those. So costs, the green bar at the top represents what we're spending per capita annually for healthcare, and it's almost $12,000. it is well more than twice what comparably wealthy nations are spending per capita, and clearly more than well over twice what Canada's spending. So I'd like you to fix this bar graph in your mind's eye, because we're going to come back to Canada and the Canadian example. This difference between what we're spending for healthcare and what the rest of the developed world is spending is not decreasing, it is increasing, as seen in this slide here. Insurance coverage. In 2021, according to the Census Bureau, 8.3% of the US population, over 27 million people, had no health insurance at any point during the year. Well, does it matter? Does it matter that people don't have health insurance? That may seem like a silly question. Of course it matters. But here's another point. Whenever you hear any statement made about the US healthcare system, ask yourself, is there evidence? Are there data that we can bring to bear on answering this question? So here are some data. These authors from the Annals of Internal Medicine a couple of years ago, controlling for every other factor that was available, found an increase of 16% in mortality simply for not having health insurance. In other words, the mortality penalty, 16% more likely to die simply if you don't have health insurance, everything else being held constant. So there is a body count to our health insurance problems. Performance. This report is issued periodically by the Commonwealth Fund, mirror, they call it, and it compares health system performance amongst the wealthy nations. The US ranks last overall, despite spending far more of our GDP on healthcare, last on access to care, last on administrative efficiency, equity, and healthcare outcomes. So here's how it looks on a graph. With healthcare system performance on the y-axis, per capita spending on the x-axis, and you can see how all the other comparably wealthy nations are clustered up here. We are the outlier. Another way of looking at it is life expectancy in years, plotted here on the y-axis, and per capita health spending on the x-axis. Again, we're the outlier. We are doing something uniquely wrong amongst all of the wealthy and not so wealthy nations of the world. So no surprise, Robert Wood Johnson's survey from last year showed that 56% of people surveyed in the United States have made sacrifices in their healthcare, in their access to healthcare because of costs. They skipped the doctor's visit. They didn't get a recommended treatment. They didn't get recommended medications. Health insurance in the United States was reviewed by the Commonwealth Fund recently. 29% of people with employer-based private health insurance and 44% of those with coverage that they purchased on the individual or marketplace were underinsured. That means they were spending 10% or more of their net annual income out of pocket on healthcare costs above and beyond the premiums they were paying for their private insurance. Almost half, 46% of respondents said they had skipped or delayed care because of the cost. 42% said they had problems paying medical bills or were paying off medical debt. Oh, 4 in 10 Americans actually, according to this Gallup poll from this past August, cut spending to cover healthcare costs. We have some data from Massachusetts, from the Center for Health Information and Analysis, which is a unit of state government. In a survey that they conducted in Massachusetts last year, they determined that, yes, the uninsurance rate in Massachusetts is only 2.4%, and that is amongst the lowest, if not the very lowest, uninsurance rate of all of the 50 states, compared to the national rate of over 9%. But 45% of residents with private health insurance are enrolled in a high deductible plan in Massachusetts. 41% experienced healthcare affordability issues, including 60% of those with moderate income. Almost a third, or 31%, reported having an unmet healthcare need due to cost. 13% reported having family medical debt. 56% of American adults in this survey from earlier this year owe a medical debt. And for those people with a medical debt, 25%, a quarter, owe $10,000 or more. Almost half, 46% of those with medical debt are delaying buying a home because of their debt. 14% are planning to declare bankruptcy this year because of their medical debt. So let's back up for a second and look at the big picture of health insurance. These are data from the Census Bureau from 2021. So we have almost over half, 54% of people across the age range, this is all ages, all individuals in the United States are reliant upon employer-based private health insurance, over half. We have about 19% on Medicaid, 18% on Medicare, 10% purchasing policies directly. There's your 8.3% uninsured. Only 3.5% on the Affordable Care Act marketplaces. And as a sidebar, if you recall the sturm and drang that was generated around the Affordable Care Act when it was being developed, it only represents 3.5% of all individuals in the United States in their insurance, and all of the military policies combined another 3.5%. So what are the problems with employer-based private health insurance that more than half of the country is dependent on? Number one, administrative complexity adds expense to the entire system. This graph in the yellow shows you the growth in the number of physicians over the last 50 years compared to the growth in managers or administrators over that time period in the blue-green. Think about it. You've got hundreds of health insurers writing thousands or tens of thousands of different policies that change constantly. It takes an army of administration personnel to keep up with this on both ends, and that's expensive. As pointed out by Bloomberg Business Week, the reason healthcare is so expensive, insurance companies. How about that? The arrangement that accounts for much of the difference between health spending in the US and all other places is the enormous administrative overhead costs that come from lodging healthcare reimbursement in the hands of insurance companies. If you only remember one slide, remember this: Bloomberg Business Week, whatever else you want to say about them, is not an organ of the left. Private health insurance costs are skyrocketing over 50% over a 10-year period compared to 21% for Medicare and 12.5% for Medicaid. The prior authorization exercise that is inserted into private employer-based health insurance can be deadly, as in this case reported in the AMA, a woman who died of cancer while waiting for prior authorization for additional tests and treatment. And that is not a single case alone. The Inspector General for HHS has produced similar reports, similar findings in this report, that Medicare Advantage organizations, will talk about Medicare Advantage, denials of prior authorization requests raise concerns, to put it mildly. Second problem with private health insurance: high out-of-pocket costs, as I've mentioned, and their consequences for patients. So here you can see in this graph from Kaiser that the average worker was paying for a family plan almost $6,000 of their income taken out for the family plan that they get through their employer. Their employer was kicking in over $16,000, and you can see how those costs have escalated in real dollars over 10 years. In Massachusetts, since the year 2000 through 2018, employee worker premium contributions have gone up 276% over that time period. Deductibles, that's the cash money you pay out of pocket for healthcare before your employer pays a nickel. That's quadrupled in the course of 12 years. Most people under age 65 who have employer-based private health insurance the proportion that are enrolled in high deductible health plans is rising, such that in 2020, almost 53% of US workers covered by private health insurance through their employer were enrolled in a high deductible health plan. And that means at minimum, they were spending $2,800 cash out of pocket before their employer paid anything. Now, here's a real world example of what this looks like. A person who's pregnant presents to the hospital, has a baby, has a normal labor and delivery, normal healthy newborn with normal neonatal care, with private employer-based health insurance, can expect to pay an average of $3,000 cash out of pocket, above and beyond what their private health insurance pays. Again, private health insurance is entirely insufficient, just in terms of the cash money that you have to spend if that's what you're relying on. So it's no surprise that in 2021, 58% of patient bad debt came from the copays and deductibles that come along with private employer-sponsored health insurance. The majority of patient bad debt, let me say it again, came from people with private health insurance, and that's up from 11% just 3 years ago. What happens when people have to pay a lot of money out of pocket? They stay away from care. Surprise. It's across all forms of care. Preventive care, office visits, mental health, emergency, it doesn't matter. And it doesn't matter how urgent the care was, or maybe it wasn't necessary. It doesn't matter. Across the board, people stay away from care if they have to pay large sums out of pocket. And there are consequences to this. Here's an example of a consequence. An increase of just over $10 in certain cardiac medications like statins and antihypertensives caused a 22.6% drop in patients filling those prescriptions. And that is calculated to be the equivalent of a 1/3 increase in monthly mortality. So here's another example of the body count that happens when we're forcing people to pay large amounts of cash out of pocket on the top of their private health insurance. Underinsurance is the norm with private health insurance. This graph shows working age adults from 2003 to 2018. So the gray bar below shows the people who had no health insurance at all during the year. And it's true that that has come down since the enactment of the Affordable Care Act. But this orange wedge here,
Yes.
which represents people who are insured but underinsured, has increased to the point where in 2018, almost a quarter of people with private health insurance were underinsured, meaning again, they were spending 10% or more cash out of pocket for healthcare above and beyond the premiums they're paying for their insurance. Half of private health insurance is for profit. Bernie Sanders pointed out that this comes to over $100 billion in profits. That's for health insurers and pharma, and that's probably an underestimate. Where does this money go? Well, here's one place it goes. 7 health insurers CEOs took in $283 million in their payouts last year. 7 health insurance CEOs, $283 million. We have to ask ourselves, is that where we want our precious healthcare dollars to be spent? I don't think so. I don't think you do either. For-profit hospitals are more expensive in this study, almost 20% more expensive, and their track record. Here's an example. Mortality at for-profit dialysis centers is 7% higher than nonprofits, and that's calculated to be the equivalent of 3,800 excess deaths. Another example of the body count. And think about it. The truth is, you can't serve two masters. You are either going to run your operation to optimize the outcome for the patient or to maximize profits for investors. You can't do both. They will always conflict. You can't serve two masters. And that's especially clear in the case of renal dialysis. There's continual churn with private health insurance. One study in Michigan, in 1 year, 28% of workers with employer-based insurance changed plans, either because the worker had a change in their job status or the employer changed what plans they were offering. And as we know in primary care, all too often, when your insurance coverage changes, you lose continuity with your primary care clinicians, and that's not a good thing. We can all agree about that. We hear this, but people love their private health insurance. Nancy Pelosi said it a couple of years ago. My response to that is, oh, really? Let's remember the principle of looking for information, for evidence, for data to bear on questions like this. Well, here's some information, some evidence. In this study in the JAMA network from June of last year, in this survey, individuals with private insurance were more likely to report poor access to care, higher costs of care, and less satisfaction with care compared with individuals covered by publicly sponsored insurance programs. How about that? It's the opposite of the claim that we just saw. So let's talk a little bit about Medicare for all. And the first point that I'd like to make is when we say Medicare for all, we do not mean expanding the age range of Medicare as it's currently configured to cover everybody in the country, rather than just old folks over age 65 like me. We don't mean that. Why do I say that? Because there are problems with, let's call it Medicare as is. Number one, it's not comprehensive. Part B only covers, that's clinician fees, only covers 80%. That means you have to buy additional coverage to cover that 20% gap, which makes it complicated and expensive. Traditional Medicare actually has a premium deducted from your Social Security payment. In my case, that's about $150 a month, but I have to buy a supplement to cover that 20%. I have to buy a drug plan, Part D, and it allows, as it's currently configured, for the entry of for-profit giant insurance corporations through the Medicare Advantage option. Basically, Medicare comes in two varieties, traditional Medicare or Medicare Advantage. And when you sign up for Medicare, you have to choose one or the other. And I'll show you some of what that means. But the Medicare Advantage alternative, some of you may have seen this article in the New York Times from a couple of years ago. Again, Medicare Advantage is how giant for-profit insurers can make money off of this nominally public insurance program. This article in the New York Times shows how major health insurers exploited the program to inflate their profits by billions of dollars by charging higher rates for sicker patients, basically what's called upcoding. The insurers made their patients appear as sick as possible, and they became substantially more costly than traditional Medicare. It was supposed to be cheaper. It's not, it's more expensive. More than 2/3 of the market of these private insurers have submitted inflated bills, and 4 or 5 of the largest players have faced federal lawsuits for fraud. Again, this is what happens when you throw that corrosive element of profit into the mix. So if you take the high-end estimate of those overages, this is just the excessive overbilling of Medicare Advantage, $25 billion. That is more than the entire budget of NASA, the Children's Health Insurance Program, Customs and Border Protection, et cetera. So it's no surprise that in 1 year, almost a quarter, 23% of US seniors, all of whom are on Medicare, citing costs, didn't go to the doctor when they were sick, didn't fill a prescription or skip the dose, didn't get a recommended test or medical treatment, again, because of the out-of-pocket costs. Now, when I signed up with Medicare, this is a screenshot of an email that I got from Medicare. They helpfully informed me that I could expect to pay for my original Medicare, my traditional Medicare, plus my Medigap policy. That's the supplement that covers the 20%, plus my Part D drug plan. I could expect to pay over $6,300 cash out of pocket for my public health insurance, and that's if I'm well. That's if I have no health problems, no medical needs at all, except my annual checkup. That's the money that I'm going to pay out of pocket for that coverage. Medicare Advantage would be, it would pay a little less, they would say, but there are problems with Medicare Advantage. So I couldn't figure it out, despite the fact that I practiced medicine at that point for 40 years. So I went to a state-sponsored advisor. The SHINE program is very helpful. I advise people to take advantage of it. And I was presented with these handouts. So it explained to me the two basic flavors of Medicare: traditional Medicare, which you supplement with your Medigap policy and your drug plan, or Medicare Advantage, which claims to put everything together all in one. So here are the Medigap policies that I could choose from with my Medicare, with my traditional Medicare. They all have different parameters, different costs, different rules that change. This year, during open enrollment, I can choose from 27 different Medicare drug plans in my zip code. Whoops, here they are. They're all different. They have different rules. They have different prices. They change all the time. This amount of complication is just plain mind-boggling. So the New York Times pointed out that, in fact, it's not just you. Picking health insurance plan is really hard. In real life, most people are terrible at picking the health plan that's right for them, as shown in study after study. And in fact, survey data shows us that 71% of Medicare beneficiaries said they didn't compare plans because of an overwhelming amount of choice, hopelessly, needlessly complicated, Medicare as is. Well, we have the opinion of Paul Ryan, as he expressed when he was majority leader a few years ago. He said this on the floor of the House. Paul Ryan said, discussing the Republicans' options for healthcare, here's the key. You buy what you want to buy. It's called free market healthcare, patient's choice, patient-centered health system. You choose the plan that meets your needs. You buy what you want to buy, not what the government tells you to buy. Well, I suppose if you had just landed on Earth from another planet and you looked at this argument, you'd say, well, yeah, that kind of makes sense. It's like the TV ad says, you only pay for what you need. But think about it. What Paul Ryan wants us to do is gamble. Health insurance is supposed to cover us for our medical needs going forward in time. And we don't know what our medical needs are going to be going forward in time. So here's an example of the gambling that Paul Ryan wants us to do. Say I'm a young, healthy person and I'm going to buy my own health insurance. And I think, well, I'm a young, healthy person. I'm going to have minimal medical needs. Because I exercise, I do everything right. So I'm going to get the skimpiest plan I can get that has the lowest premiums so I can keep more of my paycheck to myself. That's what'll suit me. And then 2 weeks later, I go out and get hit by a bus, wind up in the surgical ICU, lose everything I own, and come out with a medical debt of $100,000. That's what Paul Ryan is talking about. Think about it. We all need the same thing in that sense. We don't need choice in health insurance. We need coverage to cover us for unforeseens. None of us know what's going to happen in the next year. We all need the same thing. We can summarize it in 8 words. We all need ready access to comprehensive care without financial barriers, or better, ready access to comprehensive care with no out-of-pocket costs. That's what we all need. Our needs will be different going forward. We don't know what they're going to be. We need to be covered for them, period. So Medicare for all, I like to refer to it as improved Medicare for all, to keep making the point that we're not talking about Medicare as is for everybody. We're talking about something different. We're talking about single payer. What is single payer? It means that one payer, a unit of government, it might be the national government, it might be the state government, could even be the municipal government, picks up the medical bills. There are global budgets for hospitals, nursing homes, and other institutions. In other words, they're granted their budget for their year going forward, right? Their budget year in advance, just like the fire department, and then they can allocate it. It saves enormous amounts of money because no longer do they have to have departments full of people chasing down multiple insurers to get reimbursement for every bag of IV solution that they hang on a patient. There are uniform fee schedules for individual clinicians, price controls for drug companies, importantly, no out-of-pocket costs for the patient at the point of care, free choice of doctor, clinician, and hospital. So that's basically what Canada has achieved. This cartoon appeared in the Boston Globe during the Clinton administration's run with their managed competition scheme. Gosh, Bill, if only there were a fair, efficient way to give everyone quality, affordable health care. Well, sadly, the Clinton administration didn't look to the Canadian example, nor did the Obama administration when they were coming up with the Affordable Care Act. But we can look at the Canadian system. And if we do, remember that original chart that I showed where Canada was spending less than half of what we were. Half of the difference in what we're spending and what Canada is spending is accounted for purely by the bureaucracy that we need to manage our system. And that's true across the board. If you compare what we're spending for administration in the light blue, what Canada spends in the dark blue, physicians, home care, nursing homes, hospitals, insurance, they're spending way less on administration. It accounts for almost $2,500 per capita for us, $550 in Canada. That amounts to $600 billion a year. So it's no surprise that Canada was spending about what we were until they fully implemented their national system. And from that point, you can see how the spending has diverged. Now, people will say, oh, but in Canada, you can't get good care. Again, look for the evidence. Here is some evidence. Here is a paper that compared the life expectancy, the lifespan of patients with cystic fibrosis in Canada, 48.5 years, compared to the US, 36.8 years, almost 12 years longer of survival in Canada of patients with cystic fibrosis. And this is an important one to look at because cystic fibrosis is an inherited condition. It's uniform across populations, and it's responsive to intensive medical management. Now, a broader view, here's a paper from the Journal of Public Health Research that looked more broadly. Low-income Canadians have a 36% greater chance of getting better health care than low-income people in the United States. For the general population, 9% better chance of getting better health care in Canada compared to the United States. And look at this last one. US patients have more than twice the risk of long waits for breast or colon cancer care, or of dying while they wait for an organ transplant, more than twice the risk in the US compared to Canada. So when anyone tells you, yes, Canada has problems like everyone does, but when everyone tells you that you can't get the care there, show them some of this data. So there are bills to achieve improved Medicare for all health insurance at the national and state level. Here's the bill that's currently in the US House of Representatives. It's HR 1976, reintroduced by Premier Jayapal of Washington State last year. It now has just a bare majority of House Democrats, 121 co-sponsors. That includes 5 of our Massachusetts delegation, but not Representatives Auchincloss, Lynch, Moulton, or Neal. So I would suggest that anyone listening who might be a constituent might want to contact your rep and let them know how you feel about HR 1976 and their lack of support. Now, this bill, HR 1976, would establish a national health insurance program administered by HHS, covering all US residents, with automatic enrollment upon birth or establishment of residency, not citizenship, but residency, free choice of doctor, clinician, hospital, covering all medically necessary items and services, including dental, vision, and long-term care, which is not part of Medicare as is, prohibits cost sharing, no out-of-pocket charges. Private health insurers could only write policies that are supplemental to the public program, meaning, for example, if you wanted to get coverage for, say, cosmetic surgery or a private hospital room, should you be admitted, you could buy insurance for that. Does not affect VA or Indian Health Service coverage, has a 2-year phase-in. The equivalent bill in the Senate is 4204. It was just reintroduced this past May by Bernie Sanders. It only has 14 Democratic co-sponsors among the Senate Democrats, but does include the 2 senators from Massachusetts, Warren and Markey. Now, when you propose this to people, often the first thing they'll say is, and it's a reasonable question, how are you going to pay for it? Of course, we want to know that. My first response is, people, we're paying for what we're getting right now to the tune of $3.5 trillion a year, which is way more than we need to be spending. So, but to cut to the chase, there are a number of serious studies of the economics of single payer in the United States, and they're in high concordance that we would be saving somewhere between 10 and 15% of our healthcare expenditures because of the administrative streamlining primarily. This paper in the Lancet from 2020 did these calculations and came up with a figure of 13% savings. And oh, by the way, almost 70,000 lives saved. So the public is already with us. If we look at this recent Gallup poll, this is just from a couple of weeks ago, 44% of the people surveyed give the US healthcare system overall a D or an F, 44%. Cost of care, 75% gave it a D or an F. Equitable care, 56% gave it a D or an F. And in this survey of heads of households from a couple of years ago, 70% agreed that access to health care or to health insurance, to being covered, 70% said, yes, that's a human right. This study from Ipsos, this poll from Ipsos Reuters from 2018 showed a 70% overall agreement, people supporting Medicare for all. That included almost 85% of Democrats. And in this survey, over half, almost 52% of Republicans said, yes, we support Medicare for all. Now, I will admit that not all national polls show that level of support amongst Republicans, but they do show some reports of support. So, for example, this Kaiser tracking poll from October of 2020 showed a 53% overall support for Medicare for all. That included 77% of Democrats and 21% of Republicans. So not quite a half, but not nothing. So there is some support there, even amongst Republicans. Here's another national poll from last summer. Robert Wood Johnson found 63% support for National Health Plan, Medicare for all. Doctors are already there. 56% support in this Merritt Hawkins survey from 2017 of physicians supported single payer. And importantly, the American College of Physicians, which is the professional organization of internists, of internal medicine specialists, recommends single payer financing system as one of two methods to get to universal coverage. This is really important. The ACP, the American College of Physicians, is the second largest doctors organization in the United States, and they're endorsing single payer, and that's significant. No co-sponsor for all has lost re-election in the past decade, even in Republican-leading districts. The Congressional Budget Office recently reviewed this area and basically agrees with everything that we put forward so far. The CBO in this working paper from February of this year said that yes, the individuals would have greater taxable with a single payer system, wages would go up, healthcare costs would go down, administrative expenses would diminish, productivity and efficiency in providing healthcare would improve, longevity and lower labor productivity would increase. It is the nonpartisan Congressional Budget Office basically coming up with some pretty substantial findings on Medicare for all. Now, that PNAS paper that we looked at earlier about COVID-19 and uninsurance, the authors calculated that a single-payer universal healthcare system would have saved about 212,000 lives in 2020 alone. And again, we would have saved over $100 billion had we had single payer when the pandemic hit. Now, I mentioned that single payer could be achieved on a national level or on a state level. So this map represents states in which there are bills in their legislatures calling for single payer at the state level. I will point out that New York and California are probably the furthest down this road. So keep your eyes on the news of New York and California, but we're not that far behind in Massachusetts. In the Massachusetts House, it's bill number 1267 calling for the establishment of Medicare for all in Massachusetts. It's sponsored by Denise Garlick and Lindsay Sabadosa. In the Senate, it's bill number 766, sponsored by Jamie Eldridge. Massachusetts single payer legislation would eliminate health insurance companies and their profits, would replace the health insurance industry with a publicly funded healthcare system, healthcare financing system, no out-of-pocket cost to the patient, covering all necessary medical care, including, again, dental, vision, hearing, nursing home, and long-term care, which is currently not a part of Medicare as is. How would it be financed? Workers would pay 2.5% income tax, exempting the first $20,000. Employers would pay 7.5% of their payroll, 8% for large employers. The self-employed would pay 10%, excluding the first $20,000, and unearned income also 10%, excluding the first $20,000, not including Social Security or SSI, SSDI, unemployment, or benefit or pension plans. Now, Professor Gerald Friedman, who teaches economics at UMass Amherst, has run the numbers on projected savings, on the projected costs rather, of single payer Medicare for all in Massachusetts, and he finds that we would achieve a substantial savings, primarily by reducing administration and other waste, and that people, the average person, would do better in terms of their net income for the year. Here's how he calculates it. Anyone making over $500,000 or more would be the only groups that would pay more through these taxes than they're paying now with premiums and out-of-pocket costs for medical care. If you're making less than $500,000 a year, you would come out ahead, as shown here. And the lower your income, the more the advantage to your pocketbook for having single payer in the state at the state level. The public would save money, according to Professor Friedman's calculations. Boston would save over $293 million that it's now spending to try to cover its workforce. This graph shows support in the State House The darkly shaded districts represents a representative who has signed on to the bill. Again, it's 41% in the Massachusetts State House. In the Senate, it's 43% co-sponsors, again shown in the dark blue here. Mass Care is the umbrella organization that's working to advance single payer at the state level. 80-member coalition members representing over 500,000 people. Mass Care has a non-binding ballot question coming up this voting day in 20 districts. Shall the representative from the district be instructed to vote for legislation to create a single payer system of universal health care, providing all Massachusetts residents with comprehensive health care coverage? That's going to be question 5 everywhere but the town of Hingham, where it's question 7. So a yes vote means it's not binding, but what you would be doing is telling your representative that, yes, the voters in your district want you to get behind this bill. I'm also just going to mention other organizations that I work for, work with, not for, I'm not paid, Physicians for a National Health Program. And I encourage you to visit the website, pnhp.org, for good discussions and materials about single payer. Also, the Right Care Alliance, which is a grassroots organization that has a broad healthcare reform agenda. And I'll just end with this nice picture of our comrades in the National Nurses United, which is the largest nurses union in the country and one of the very strongest national voices for Medicare for all. So thanks, and I think at this point we can stop sharing and move on with our program.
Alan, thank you much. That is just brilliant presentation, and it's so current and present relating to the ballot question. But it's a wonderful educational tool, and we really are urging everybody we will have it on YouTube, and we will circulate this, so to use it as an educational tool in your districts, both for the ballot question, but for the continuing dialogue that we're going to have with our legislators on. We will refile in January a new Massachusetts Medicare for All bill, and you will hear about it. But we also have these wonderful brochures that we are distributing to all of the 20 districts that we are currently circulating in. I am I'm going door to door and speaking Mariano's district in Quincy, and we have other folks here that are doing the same thing in the rest of his district, and that is happening statewide in those 20 districts. You can go to the Mass Care for All website to see exactly which district if you want to get that information out. But we wanted to ask, open up for questions for anybody here or comments. I know we've got Heather here and Lynn and John Wiseman, who have been working heavily on this, and many others. So we'll open up the mic to everybody who wants to offer a question or comment. Is that your hand, Denise?
Oh, yes.
Yes, Denise, yeah.
How was it decided which district was going to have the question this coming election cycle? And also, it's not an option where I live. How can we be helpful if we don't live, in a district that have it on the ballot? And again, how was it decided which district to have it?
I think at this point we could only afford to, and this is an all volunteer effort, so we could only afford to do it in so many districts. On the South Shore, we collected a number of signatures. There's a process you go through and collect signatures. And we had 26 districts with signatures, but by the time clerks of court rule out districts, we got down to 20 districts. But it's really a bandwidth issue in terms of how many volunteers you have.
Actually, Bonnie,
yeah,
I think I might be also able to cast some light on that for Denise. We targeted only Democrats who who were not co-sponsoring the Medicare for All bill, okay, but who we felt were tippable. In other words, we felt that there was enough support within their districts that if we could run a successful ballot campaign, that we could push them to co-sponsor. So there was some strategy around that. And then from among that group, we had to look at where our resources were. Where did we have the volunteer resources that could hit the ground, collect the signatures, do the campaigning? And so that was how those 20 districts emerged as the target districts in this. As far as what you can do to help if it's not in your district, oh my heavens, there's 20 where you could be knocking doors. But Lynn Newkirk, who's also on this call, may in fact be able to talk a little bit about some strategy around some text banking that we're working around. There's been some talk of some phone banking, which can be a little bit more complex. But if there's a district near you, I don't know, what district, what town do you live in, Denise?
JP.
In JP. Well, you know what? You're probably lucky because your state rep probably already co-sponsored. But yeah, I think that there's a Dorchester district that they've targeted as, I remember Stephanie Nakajima's district in Dorchester is definitely one, sort of there's a Dorchester Mattapan district. So we can probably get that information to you. It's probably not far from me.
So and that would be great for me because I worked for 50 years in Dorchester. So it would be a good place for me to do outreach.
Good. You don't have to say it twice. We're going to nail you, Denise.
Okay. Lynn, I think you're on the call. You have some suggestions?
Hi, I am on the call. Yes, we do. Actually, we're set up for phone banking now. I know Stephanie just sent out an email encouraging people to sign up for that. And as we said, there's Dan Hunt's district and
that's in Dorchester.
Yep. There's a couple other districts in that area that Denise, we could certainly use some help with, but with the phone bankings. So I have made a note. I'm going to make sure that we get in touch with you to follow up.
And you
Thanks,
can also
Denise.
go on MassCare's website and you just sign up and they will keep you informed and give you all sorts of options that you can help with. So anybody else here? Do I see hands? A show of hands.
We have hands from John and Sandy.
So John, oh, good. Thank you, John. Comments and questions?
I just wanted to add that in Western Mass, we selected the districts. Collaboratively, we have a Western Mass Medicare for All hub of mass care. And so we met and decided that priority would go to open seats. We had 2 very important open seats. Priority would go to districts that had not been, we've been doing this for 20 years now. So we have a lot of districts in Western Mass that have been surveyed already. So we prioritized districts that were not surveyed. They tend to be more conservative. They tend to be the Springfield suburbs. And then we also had a couple of districts were lobbied for by people who lived there who they just wanted to do it. And so even if the person, in one case, the representative is a co-sponsor of the bill, we're still running the ballot question in that district. And that's because this is not just about polling the voters. It's also about building what we call hubs in all 160 districts, if we can, so that every legislator is accountable to a group of single payer activists. Thanks.
Thank you so much, John. Sandy Eaton, another nurse from Quincy.
Yeah, thanks very much, Bonnie. I agree with the decision-making process. I just want to say for Denise's sake, there are 2 state rep districts sort of splitting Jamaica Plain. We are on the ballot in Liz Molly's district. And that and the Jamaica Plain Progressives, that group is spearheading. That's our hub on that district. There's one interesting anecdote through comments on the Mass Care webpage. There was a young man, I presume he's young, up in Newburyport, who was so enthused and so desperate for change in the way we do healthcare that he by himself went out and got the signatures needed to put it on his district up in Essex County, up in Newburyport, in Newbury, in that area, and a district that is normally Republican. It happens to be vacant at this moment. That's all. One other anecdote in terms of our relationship with our state legislators. A few years ago, in my district, in the 2nd Norfolk and Quincy, our state rep, we got it on the ballot. And the state rep at that time, not the current one, the state rep at that time was so foolish as to mention in front of a Patriot Ledger reporter that he didn't care how people voted. He still wasn't going to support single payer universal health care. That made the front page of the newspaper the next day. And we got our highest numbers there, 77.7% yes, when it came down. So that legislator who was opposed to us was probably our best advertiser, because it gave us the hook to the newspaper. And there are opportunities like this everywhere, as well as door to door, as well as the phone banking that you need to hook in for, because that's where we're going to be reaching into parts of the state where we don't have a strong organization built at the grassroots, but we are on the ballot. There are a few of those, particularly in central Massachusetts. Worcester County is going to be a phone banking target.
Fabulous. Any other questions, comments that people want to share? This has been wonderful. We are, thanks to Dr. Meyers, we have a fabulous new video. We want you to be, Hank, Maine Healthcare for All. Join us. Yeah.
Sure. Sorry we couldn't get our statewide initiative off the ground this year, but it was interesting to hear the creativity and the options of doing it by district. I think it's great. Way to go, folks, and we'll be interested in listening. In particular, the question I have is the analysis for savings by cities. I hadn't seen that before. That will be available in a slide set or in the YouTube or something like that, because that is another persuasive argument, is this.
Exactly.
The towns and cities can get out of healthcare financing and go worry about education and infrastructure. And both of those will do better.
Yeah, right, exactly.
So
It will be on,
available.
We'll be on Mass Peace Action YouTube channel, and it will be Vote Yes on Medicare for All, question 5. And it will also be distributed to every network of Medicare for All network, statewide and nationally. Campaign for single payer. I mean, we'll circulate it around every place and post it every place. And so use the information and material. Alan has spent months putting together his new presentation, and it was just so powerful and just so I hope it will move people. It certainly moved me, and I hope it will move the rest of Massachusetts and the United States. Any other questions or comments, thoughts on anybody's part? I can't see everybody's hands. You were all set. Thank you.
I have another question.
Yes.
I'm sorry to monopolize.
That's fine. Yeah.
But I'm
Denise has been a nurse for 50 years. So it's more, I mean, what are you supposed to do as somebody who needs, who is on Medicare, who needs to get supplement coverage? I mean, I have now Medicare Advantage. I mean, I haven't had it for very long. I feel kind of guilty because I'm supporting, but am I doing better by getting Blue Cross Blue Shield Medigap? I mean, does it make a difference? What are you supposed to do? Alan, I'm going to give that to you.
Oh boy, that's Denise. It's a complicated question.
Yeah,
and
it
in
is.
part it depends on what happens to you.
Yeah.
And the general, the scene with Medicare Advantage is if you're if you don't have certain needs, it may be great. But if, you know, the trade-off is the narrow network, that you can't go to certain clinicians and certain hospitals and certain institutions for Medicare Advantage plans. And, you know, when you get, and hopefully you don't, but if you have some big time medical need, that's when the foot dragging starts and the delay. And, you know, this New York Times article, for example, the amount of there was just another article today about this. I think it was, it was on one of the medical, the newsletters. The frequency with which they demand prior authorization, for example, throws delays into people's care. And in certain, you know, people with certain conditions, you know, rapidly advancing cancer, that can be very adverse. I don't want to tell you, I'd be foolish for me to say you should do this or do that.
No, I understand.
And I think I understand there are some problems in people trying to get out of Medicare Advantage and into traditional Medicare. I think some of the problems are that if you have a pre-existing condition, that may be problematic in switching back into traditional Medicare. But, you know, I will say that the counselors, they're called Shine counselors. I can't remember what that stands for, but it's operated by the state. It's free. They work out of local senior centers. It's very helpful. And so I'd say they're way beyond me. They're the experts. They who I went to figure out what to do. And I just wound up with looked like the, you know, the simplest thing that I could choose, which was, you know, to get the traditional Medicare with a Medigap plan. I would suggest talking to those folks.
Yes.
About your own situation.
Yeah. Shine is a great organization and it's free. It's a wonderful resource through senior centers. And Alan highlighted his own search as he was going through making decisions on it, on the video. So you can, when you get the video, you'll be able to review it again and see, you know, what some of the choices and options are. But Shine is the best place to go for helping with decision making on it.
Because it's so complicated. People need help.
Exactly. Yeah. And
I
we're
did.
all in the medical profession and we all needed help. So this is for, can you imagine for the layperson trying to figure it out? It is hard, no question. So any other questions or comments? Heather, yes.
Yes. Hi. I'll try to make it quick. You know, Alan, you've made the point. You've made the point that, you know, we've won the moral argument. We've won the financial argument. We have won the medical argument. I mean, there is no rational reason for us not to have a single payer system. But of course, it's the political case, the political will. And, you know, as I've been knocking doors for the question here in the South Shore, folks have been, you know, universally happy and grateful to have you show up at their door and provide them with some voter information. And when they hear it's about, you know, universal health care, you can see their ears prick up. You don't necessarily know whether they're positively inclined or negatively inclined, but they know it's an issue, right? So, you know, so I think that the political, you know, the ground is fertile. The ground is fertile for that. In any case, the issue that I'm encountering, you know, against these very positive conversations is basically a lack of trust. What I'm seeing, what I'm hearing from folks who say to me, I like this idea, or I'm inclined to do this, or if only, you know, no, I'm not talking about the people who are like, that's socialized medicine, right? I don't bother talking to them, right? But when I encounter people who, you know, really do want something better and understand that we can't keep doing what we're doing, what I encounter is a lack of trust. They don't trust, you know, that if they have their insurance taken away, that something better will be there to take its place. So that's, and they know that money rules politics, and I can't argue with them on that front, right? I mean, they're right. And so there is this deep distrust of institutions, of our political leaders, and our capacity to get this job done. So obviously, this is an entire, question for another conversation. It would be interesting. I'm sure that Mass Peace Action encounters similar types of pushback to some of the issues that they're bringing forward. If only, I don't trust them to do the right thing. So I mean, that would be the, most of what I'm getting is positive. People are either, super enthusiastic or positively, they lean positive once they've had a conversation. But it's that trust issue.
Yeah.
Let me make one suggestion, and it's a phrase that we didn't use tonight, which is my response if I were confronted by someone who voicing that concern is, look, what we're talking about is a system under which, with everyone in, nobody out. Every single person in the country would be getting the same thing. So we would have the power of the entire population to make this work. Because if it doesn't work for you, it's not going to work for anyone. So the fact that the political power of the entire population behind it because everybody's getting the same thing. That's the quickest sort of immediate answer that I would come into my mind. If someone says, I don't trust that it'll work. Well, you know what? If it's not working for you, it's not working for your neighbor, and it's not working for anybody in the country. So it's going to work because everybody's in, nobody's out.
Right. Hank, you were next.
Yes, I think Denise brought up a good point, and actually in our board meeting today for Maine All Care, we sort of discussed what do we do with the people who are happy in Medicare Advantage, or the sort of lower middle class people who have to choose it because they don't have the money to buy, or the copay, or the low cost, or the zero cost entry point. And again, we were having a discussion is how to frame that argument, and any thoughts, but we came up with, well, we don't begrudge you for choosing Medicare Advantage. It's a short-term solution. However, there's the moral argument and the cost argument and the nation's getting ripped off argument and the taxpayers are getting ripped off argument. And so so that's point 2, but point 3 is it may not be a long-term solution for you either as you age into other illnesses. So those are like the 3. We actually kind of discussed this at our board meeting. What do we do with folks who say, but I kind of like my Medicare Advantage plan. It doesn't cost me anything. And I'm a healthy, I'm elder but healthy. And
until you get sick, it doesn't cost you anything.
Right.
Yeah. So those are the 3 points, but it'll take some work on framing that.
Yes, I think. Hank, thank you.
And
Hank,
also, Hank, to your earlier points about, obviously if somebody is a committed, like, I'm against tax waste, then you can run with those early arguments you talked about. But I do think it's critical for people like not to feel bad about the fact that they're letting the public down if they chose Medicare. You get into this dilemma. I think that Alan's point that the point of insurance is to insure you against something you can't anticipate, right? And Medicare Advantage may work for you now, but what you really need to be thinking about is the what ifs, right? So, I mean, to the extent that might not allow someone to actually disenroll from Medicare Advantage and enroll in Medicare, but at least it frames it as, this is Medicare Advantage is answering the wrong question, right? The right question is, what are you going to need later? And, but anyway, you bring up a really interesting dilemma, and I think it's the exact same issue that we encounter here in Massachusetts with people who are, relatively well privately insured. They don't want to give up what they have, their perceived privilege. They do not want to give that up. And that's a tough sell. With folks, I live in a, well-heeled suburb of Boston. People here for the most part, have decent insurance. So how do I make this case to them? And mostly for me, I make it that they're being ripped off. They're not getting what they're paying for, right? They're just not getting what they're paying for. I don't know if that has any application in that setting.
In America, we know what separate but equal is. right? I mean, we have a history of something called separate but equal.
Mhm.
So Americans, I think in the back of their mind knowing, yeah, as long as I'm more equal and you're separate. And that's the fear issue that we have in our history.
Mhm. And gets just promoted endlessly. Michael, you had a comment question?
I was just gonna comment that I don't want to. I think that things been going now for over an hour, so probably people are getting tired.
It's okay. They'll drop off if they need to. Yeah, we want
Yeah.
to. You're the last commenting question, I think. Anyway,
Okay, well,
Yeah.
I've been involved in a course to try to make myself employable. I just turned 65, so theoretically, I'm at that golden spot where I retire and go riding off into the sunset. But my financial circumstances don't allow that. So now at the age of 65, I'm training to go into the medical care field as an administrative person. And I just was reading when you were talking about Medicare as is. That's exactly what I've been reading about. I even got a book about it, Medicare for Dummies, and it goes into a lot of that very involved language. And I was looking at a couple of recommendations to visit Medicare, Medicaid official sites that were supposed to have more in-depth information about Medicare Advantage and Medigap programs. And when I went to those sites, of course, there were links to these insurance companies, but the links don't give me any of the fundamental information. They just repeat what I've already read in the book about this is the dollar cutoff for this point, and you get 60 days of hospitalization for this amount, and then after that it's $352 or whatever. And they give you these different alternatives, but they don't really tell you. First of all, it doesn't tell you what the cost is of each plan, at least not in the link that I saw. And then second of all, they just it's almost like it's just repeating the baseline information. It's not really answering my questions. So I don't know how many folks here have had to deal with going on Medicare because they turned 65, but I understand that business about people saying it's too damn complicated. And I appreciate you mentioning the Shine people, because that was even mentioned in the book for folks that didn't want to wade through this stuff trying to figure it out themselves. They could call that was mentioned specifically in the book as a source of
they're wonderful, and they really keep up with all the changing. It's ever changing.
Yeah, and I think the other thing that strikes me about this is that, you know, when Dr. Meyers was quoting the news articles and whatnot, obviously that stuff is kind of chosen to make it sound like, you know, we're at a major crisis point and this person died because of a shortcoming in the system, and that, you know, person was in debt up to their ears and because of another situation. And I know that I've got health conditions. I had a heart attack 4 years ago. I've been most of my life a diabetic, so I've got complications. So I know my health is likely going to deteriorate as I get older. So I'm not going to be looking at what's going to cost me the least amount of money. I want to look at what's provide me the most care as I need it.
Yeah.
You know, so that, you know, that gets to be, you're talking about talking to the insurance man. It's like, you know, it gets so complicated, and people have, it said in the book here that I was reading that people choose their plans because somebody makes it sound nice and easy, that they met at a coffee shop, some insurance representative talked them into it. They didn't actually look at what they were getting for their money. And it turns out that they probably would have done better off if they had a Shine person, or if they had taken the time to go through the Medigap programs and figure out what was the most likely to help them. But everybody wants to believe I can get something for nothing, you know, or I can get most everything for almost nothing. And they're easily convinced by a salesperson that that's the way it is. And
they sold the bill of goods.
It's almost like Americans make this assumption that we can't trust the government, but we can trust scam artists. they're ultimately trustworthy, but the government's not trustworthy. And
Yep.
there's that whole break in who
Right.
you trust and who you don't trust. It
Right.
doesn't make a lot of sense when you see the results,
Well, it does come down to trust, but I think any other comments and questions, we're gonna, if not, I think we will. Just a reminder, 20 districts across the state, go to masscare.org to figure out which districts, and you can help out, contact them, and they will let you know how you can help across the state in districts across the state. And just a reminder, this is not going away. We'll use this as an educational tool and to influence policy. We expect we will continue to get all approval ratings that are generally above 70. And we will use that this January when we refile bills in Massachusetts on Medicare for all. So again, this is your time to reach out, both with the ballot question, but we will be back refiling in January and we will keep you posted. So thank you so much for attending the webinar. We really appreciate your participation. Special thanks go to Dr. Ellen Meyers, who has been so fabulous over so many years through Mass Care, Physicians for National Health, and so many other advocacy organizations. He's a stellar advocate, and we thank him. Anybody else have any thoughts, questions?
Thank you, Bonnie.
No problem.
Thanks,
No
Bonnie.
problem. It's a wonderful
thanks, Alan.
group here. Take care and go
Thanks to
forth
everybody.
and multiply this video.
Okay.
Okay.